I'm Dr. Keith Crawford. I'm the Director of Clinical Trials and Patient at Prostate Health Education Network, and I'd like to welcome you to our May 20th um, learning session. Uh, this learning session is a very interesting clinical trial that we're going to discuss. There's two of them we'd like to discuss. And what we want to do here is just thank you again for attending, and I'd like to thank our sponsor, and I'd like to thank those in attendance. I know it's kind of late in the day, and a lot of people have other things they can do, but we have some interesting clinical trials to discuss with you. So the first thing, the name of these clinical trials are Omaha-003 and Omaha-004. And these are clinical trials for people who have metastatic castration-resistant prostate cancer. Now, during our fireside chat tonight, first Dr. Pedro Barata will be our speaker, who will review the clinical trials, and then we'll have a fireside chat that will go into a little bit more details, kind of clarify things that people don't understand. So Dr. Barata is a medical oncologist at the University Hospital at Seidman Cancer Center. He's associate professor of medicine at Case Western University School of Medicine, director of clinical genitourinary medicine oncology research program at University Hospital Seidman Cancer Center. Is clinical and research interests include prostate cancer, clinical research, experimental therapeutics, molecular profiling, genomic-based therapies for genital urinary tumors. So now before we start, and I bring Dr. Barata on, I just want to just make sure that we understand what our objectives are tonight. And we're going to do our very best to get you to understand what metastatic castration-resistant prostate cancer means. That's the first thing. And then we are not going to go into too deep, but we want you to understand just the basic purpose for the Omaha-003 and Omaha-004 clinical trials. We're going to understand the difference between the two trials at a very high level and really recognize and discuss prior treatments and eligibility, understanding hormone replacement therapy, especially for the therapy the drug that we'll be using, and identify some questions that you might want to speak to when you speak to your oncologist about, so you're better able to share this decision-making process. So, Dr. Barata, can I bring you online?
Can you see me, Dr. Crawford?
Yes, I can see.
Okay, wonderful.
Okay, is that Cleveland?
Yes, Seidman Cancer Center. It's a very generous family supported. The cancer network here for Case Western UH in Cleveland, Ohio. So it's my humble way of recognizing their philanthropic support to the cancer center. Okay, so I appreciate that introduction. It makes a lot of sense. I think you alluded to this. We have a few slides. Some of them are more or less complex, so we'll try to break it down as much as we can. And then, of course, we're more than happy to address questions, break it down, say it in different ways, so if it makes sense. So I'm pulling up the slides as we speak. I'll do my best again to break it down in a way. Let's see here. Stop sharing. Let's see. Okay. Can you see the title?
Yes, we can.
Okay, wonderful. So we have a few goals today. So we'll talk a little bit about prostate cancer, why these studies, what are clinical trials, and what about Omaha program? What does that mean? What is it doing? And then we'll wrap it up. So that's me. I'm basically a cancer doctor, but I only do prostate cancer, kidney cancer for a living. I run the program at Case Western here in Cleveland. And I run clinical trials for a living, basically, basically kidney cancer and prostate cancer. Okay. So when we think of prostate cancer, so keep in mind, cancer started in the prostate, which is a gland underneath the bladder. And some cells inside that gland go crazy and they replicate very fast and they leave the prostate and go to other places in the body. So every time we see that, we call that stage 4 or metastatic disease. So cancer means it has the chance to leave the prostate and go to other places of the body. So when we see spots in the bones or in the lung or in the liver, It's not liver cancer, it's not lung cancer, it's prostate cancer in those spots, right? The backbone of everything we do for stage 4 prostate cancer is reduce the levels of testosterone in the body. Why? Because they feed prostate cancer. So we call that, the technical name for this pathway in the body is called androgen signaling pathway. So complicated name, that means we have hormones in our body. Those hormones going inside the cancer makes the cancer grow and proliferate. So by reducing those hormones, in general, the male hormone is known as testosterone. We reduce that, and by doing that, cancer goes to sleep. So that works for quite some time, but at some point, the cancer gets smarter and overcomes that low testosterone level, and it becomes resistant to hormones. Now, when we reduce the hormones, a technical but horrible name, it's not a very nice name, is called castration. And it's medical castration, it's not surgical castration, right? Like we don't remove the testes. However, we give a shot or a pill and we keep the testosterone levels low while we do that. So at some point, cancer starts growing despite having low levels of testosterone. So when that happens, we call castration-resistant prostate cancer or castration-resistant disease.
Now, is that, sorry for interrupting, but is that the same as hormone resistance? You know,
it is the same. They can be used interchangeably. Hormone sensitive PC, CRPC, there are different ways to designate the same thing. We're referring to the same thing. The name is, by the way, is changing again. We're trying to get rid of the name castration. So ADM, anyway, ADM, it might be another designation, but I'll use the terminology that the trial is using so people get familiar with that.
Right.
So when you become resistant to hormones, that's basically what's in this slide. We have to discuss treatments, right? What treatments are out there that can put the cancer back asleep, basically. And we have several treatments, that's the good news, that we can use. And those depend a lot on a lot of things. It depends on where the cancer is at that point. It matters how healthy the patient is. It matters patient's preference as well. It matters treatments available. In some places of the world, not everything is available. Also the awareness or knowledge of the care teams, right? Some teams may not have access to the novel treatments, for example, or have not used it yet. Or logistically, they're not there, they're not available. And so that conversation, it's a very personalized based conversation, and some of the treatments have shown to make people live longer and control the cancer successfully. So that's the good news. And that includes things like target treatments, chemotherapy, special types of radiation, clinical trials. I'll get to that in a second. Sometimes immunotherapy, it's not commonly used for prostate cancer, but we use it for a subset of people when we have a special marker. So all of that conversation happens, when someone develops castration-resistant disease, CRPC. Okay, I'll use the term CRPC. Keep in mind, cancer is growing despite low levels of testosterone. And then we're gonna just discuss what we're gonna do next to put the cancer back asleep. Okay, if the cancer goes back asleep, we still call it CRPC. So once the tumor is CRPC, it continues to be CRPC, even if it's under control. Okay, so with that said, I said one of the options is clinical trials. In fact, we have clinical trials in every single step of the way. So what is that? So a clinical trial is basically an intervention, can be a treatment or not. It can be a surgery, it can be radiation. It is an intervention that we do with patients and for patients. So basically, it's a well-controlled design study that is trying to answer a question that we don't know yet. And there's a rationale and a biological explanation and rationale to conduct it. And once we get the answer, we move the field forward. So let me give an example, just generic speaking. Let's say treatment A, it's amazing, it's super successful. We have data shows this is great. We have to prove that treatment A is better than what we currently have. And so if that's the case, we would have to run a trial to show that A is better than, let's call it standard of care. So that you run a clinical trial, patients will get A or get the standard of care. We do statistics around the trial design so that we can, at the end of the trial, say A is better or not. If A is not better, we don't use A. If it's better, A becomes new standard of care. So again, it's an intervention. It doesn't. Sometimes we combine it with what we already have. Sometimes when the data is evident, we compare against what we have. Sometimes it's not even a treatment. Sometimes it might just very well be exercise, right? So for example, there's a study that shows that exercise makes people live longer. They live better and live longer. So you randomize patients. Some will do a very organized exercise program, others don't. So it doesn't need to be a treatment, okay? So clinical trial, that's what it means. Now, what I will say is it has to be approved by multiple entities, including ethics committees, including regulatory agencies. So the sense that I'm being a guinea pig, which is a myth around clinical trials, I hope after today, if you have that idea, please don't, because when we design the trial, it has to be approved ethically. What does that mean? Patients sit on those boards, as well as physicians, as well as research team, as well as regulatory people, patient advocacy, to say this is appropriate to do. So he guarantees that whoever enrolls in a clinical trial does not get less than optimal treatment for their care. So there's a guarantee when we run a trial that we're not offering something that's not appropriate in that setting. Okay, so you have a number of checks and balances to ensure that is the case. Okay, so all the trials we run in the United States, they have to be approved. They are registered on clinicaltrials.gov, and that's a way to say, you know what, this is legit. We have a number of bodies that really sign off on this, meaning this is appropriate, this can be done, and does make sense. Now, with that said, we don't have all the trials at every single site, right? Because we cannot run 100 trials in each place. So we have to choose what trials to do. Sometimes we design them. Sometimes we bring trials to our centers that a sponsor puts them together. And that's the context of what we're talking today, okay? So we spoke about prostate cancer. We spoke about metastatic or advanced prostate cancer.
Right.
We spoke about CRPC. And we spoke about what a clinical trial is, and which means basically an intervention, which can be, but not necessarily a treatment. So we also spoke about that hormone pathway. So going back to that story, prostate cancer thrives, grows with hormones. So when we lower testosterone in our body, cancer goes to sleep, but then it becomes resistant at some point. Sometimes it's 2, 3, 5 years later. So let's talk a little bit about this very complicated name, opevesostat, and what it is. Let's call it a special hormonal treatment. So why is that? Well, we know that even when we load testosterone, we have other ways to block that hormonal pathway more profoundly, more intensely. And by doing so, we can put the cancer back asleep. So this drug, let's call it opevesostat, right, is a newer form of hormonal treatment. The technical way is a CYP11A1, which is a protein that basically blocks that steroid pathway, if you will. And by doing so, the goal of the game is to slow or stop prostate cancer from growing after progressing despite low levels of testosterone. So in other words, you block the hormones, cancer goes to sleep, cancer starts growing again, that's CRPC. You test opevesostat, and cancer goes back asleep. So there's preliminary data that has shown that opevesostat has the ability to get the cancer back asleep. And I don't want to make it too complicated, but one way to do this is by shutting down the adrenal glands. And so a number of trials were put together to prove if doing that is better than an alternative way of blocking hormones, okay? So the reason why it's important just to spend a second on blocking the adrenal glands. The adrenal glands are organs on top of the kidneys and are responsible to produce steroids in our body. We all need steroids. We have steroids in our body. Well, our body produces them. In fact, we cannot live without them. It regulates our blood pressure, regulates our heart beat, etc. So by blocking the adrenal glands, the medication, by doing so, it can induce what we call adrenal insufficiency. In other words, the adrenal glands are not doing the job. So sometimes it's necessary, in fact, to give steroids to compensate, to replace the steroids that the body produces. Okay? So basically, that's why we give hormonal replacement therapy, along with this inhibitor of the protein CYP11A1 of opevesostat, so that we prevent that from happening. Okay, so with that in mind, so if we understand what this medication does, it's a novel generation of blocking the hormones. How do we test that in CRPC? Well, a simple way so the intervention is the medication, right? So it's opevesostat, right? Now we need to ask the question, if there's preliminary data saying that already does the job, the question is it better than what we had before or what we're using today? So the studies are comparing opevesostat against normal standard of care hormonal therapies. We call them ARPIs, which is basically novel hormonal therapies that we use in the CRPC setting. Their names are abiraterone or enzalutamide. So basically the trials are comparing O against Abi or Enza. That's pretty much the comparison, okay? So just going back to the hormone replacement therapy, so when you're using opevesostat, you're using along with steroids, dexamethasone, fludrocortisone, so you don't have problems from adrenal insufficiency, okay? So that's that. So we do that for everybody. There's a kit. Patients take a kit home if needed, but in the meantime, they take that on a daily basis. And here's the adrenal crisis or adrenal insufficiency, if you will. So, sometimes when you're lacking a lot of steroids, you're not doing well. It's almost like you're out of battery. You're out of battery, you're out of juice, you go very weak, and your blood pressure is low, your heart beat is actually going down, you can have nausea, etc. This is all things that could happen in cases where patients are not having the steroids they need, right? So we already know this. So we give steroids replacement to patients so that are aware of this. And we have experience with this in our site, and that's basically a way to prevent this from happening, okay? So it's just more like awareness, if you will, okay? So how do we manage this? Well, you're taking dexamethasone, you're taking fludrocortisone. If we still suspect adrenal insufficiency happening, we have actually medication for that. We have the kit, an emergency kit at home. And in case we think there's an adrenal insufficiency, we call it adrenal crisis going on, people have a kit at home and it can administer right away. The use of these kits has been extremely low, I will say. It's just, again, awareness. So folks are aware. It's a very important topic, in case patients are assigned to the investigational medication. So treatment on the trials, both Omaha-003, Omaha-004. Why two trials? Both in the CRPC, Omaha-003 is later for patients who already got chemotherapy before. Omaha-004 happens before you've received chemotherapy. So no matter where you are in the CRPC space, you could be potentially eligible for the trial whether or not you've received those chemotherapy that we use for prostate cancer. And as I said, the randomization is clear. Either we go with, opevesostat or we go with abiraterone or enzalutamide. Abiraterone or enza, the doctor will discuss with the patient which one, and we go on it. Usually it's the one we haven't used before, and we basically keep patients on the study while it's helping patients, or until it stops working, or unless there's some toxicity that we say, you know what, we're not doing well on this medication, you come off, right? So that's really the design. The design is very similar. The setting is different. That's why you have these two trials which are phase threes. I should say it's a phase three trial, so it's the last stage of development. If the trials are positive, what that means is if the group of patients who receive opevesostat did even better than the comparison, the regulatory agency looks at the data, and if the trial is positive, then the opevesostat becomes available to everyone without going on a clinical trial, basically, okay? When you enroll in the trial, you know which arm you're going to go on, so there's no secret here, and it's basically how it runs, okay? By the way, that's not the doctor who decides who goes on what. It's actually a computer. It's called randomization. It's central randomization. So there's no like cherry picking which way to go, if you will. And then that's communicated to the investigator. That's communicated to the patient and the family. Okay. Now this is no subject to discussion. In other words, there's no subjectivity. Either a patient is eligible or is not eligible. So we put the package together. We need scans, we need blood work, we need to do AKG, etc. So we put the package together, we analyze it. The quality control analyzes it well, and the ethics signs off. The sponsor looks at it as well. So everybody's looking at that, and that's basically no bending the rules, right? It's a defined list of eligibility. And that's the work that the providers do and the investigational team does with the patient and the family, explain the situation, and say, you know what, I think you're eligible, you can do it, you're still interested. And by the way, if you enroll, you can come off the next second, right? So patients always have the freedom to say, I'm out, I don't want to do this anymore, I don't like you, I want to fire you, or I don't feel well. Any reason is a good reason to come off trial. And that's true for any trial, by the way. So you're not buying a house where you're stuck with the house, whether you like it or not, right? When you enroll in a clinical trial, the power is with you to say, it doesn't fit my needs anymore. Now, I tell this to my patients all the time, listen, the trial exists to help you, not you to help the trial. So we'll use the trial while it helps us. So if it's doing the job of controlling the cancer, that's great. If it's not doing that, you will recommend the next step of action, right? So you should count with your care team on your side to help you out making decisions at any time along the way, okay? So that's that. And then how long you stay on trial, I believe I addressed this. It depends how you're doing. You're not doing great, you come off, that's okay. It's not working anymore, you come off, that's okay. There's this is all defined, but the most important message, in my opinion, is you basically stay on study while it makes sense for you, right? And the team is here to help as well. There's a number of schedule. So one of the limitations of being on trial is you have to go to the site that you enroll. So sometimes people, well, what about I just go closer home? Sometimes the trial is not available there, right? So it needs to be available at the site where you're having your care. And so, that's important. Sometimes you can do blood work closer home to facilitate, or scans. And that is discussed with the care team. They'll explain to you what you need and don't need to do. Sometimes on trial, they provide the medication for you for free, which is a pearl, I guess. Some patients get the medication, they come to see us, and they take the medication home, and then you have a diary where you basically write down, I took it, I didn't take it, whatever happened, and you write it down. So it's a very objective way to measure what's happening, right? So I actually should share with this group, patients who enroll in clinical trials, they always do better, even if they have the same medication that they would get outside a clinical trial. Why? Because there's a lot of eyes on the patient.
A lot of eyes on the patient.
Yes. So everybody's doing things on the book. There's no dropping missing appointments. There's no dropping scans. There's no dropping labs. Everybody's paying attention to it. There's a rigorous process of paying attention to things every single time on a almost obsessive way. So that guarantees that whatever happens, we'll know right away, immediately, right? And you have a lot of people available on the phone 24/7. So a lot of patients, once they go on trial, they actually love the experience because they feel like, oh my God, I have a lot of people on my end, right? Like on my team, on my corner, and people like that a lot. So that's that. There are different phases on the trial. Like when we give you the consent, you go home and read, and you come back. You don't sign the day we tell you about it because we don't want to be persuaded to sign that moment. You go through what we call the screening period, where we put the package together. Then you enroll, we start, we call it the treatment period. If the treatment is done, is over, you go through what we call a follow-up period and then a long-term follow-up period. So ideally, if we can, we would like to continue to collect data anonymously, but to data to say what happened to every single patient on the trial. Why? Because it allows us to evaluate those several hundreds of patients at the very end. And that's what allows us to determine whether or not the trial was positive, right? So it's extremely important. I would encourage you all, if possible, to allow the research team to capture the information about what is going on with you, even if you after coming off trial, okay? Or because sometimes you come off trial the treatment, but you don't necessarily need to come off trial for follow-up. So some patients stay off the medication and they're still on the follow-up portion of the study, okay?
Okay. All right.
And just kind of think I'm wrapping it up. I think it's a final slide just to say this is registered. So for these trials, but all others, you can go online. It's called clinicaltrials.gov. They have a specific, unique national clinical trial number, so NCT. You can see the both for both Omahas. You can also get this QR code if you want to read more about it. And I think I shared enough for now. Again,
Yeah.
this is a new intervention. The goal of the game is to see if it helps patients with CRPC to put the cancer back asleep longer than what we currently have. And we're doing it for pre-chemo and post-chemo, so both scenarios. And that intervention is in the form of these large randomized phase 3 trials. They're available all over the world. There are large international studies. I would encourage you to read more about it. And maybe you're eligible. Maybe you want to consider it for your care. So I know we have Q&A, happy to
Yeah.
talk
And
about
then,
this or anything that come up. Thank you.
okay, so that's perfect. I wanted to make sure, and thank you again. And that everyone has to understand that the information you're learning here is for educational purposes. Okay. And that's one of the most important things. And as we move into the Q&A, the opinions that you hear will be the opinions that you saw the disclaimer earlier, but it'll be the opinions of PHEN and opinions of Dr. Barata when we go into the fireside chat portion of it. Jerry, and what I like to do is you had an idea, you got an overview of these two clinical trials, an overview of some key points: metastatic castration-resistant, your treatment options. What is a clinical trial? Okay, we talked a little bit about about the drug itself and its opevesostat. But there's another name you may hear is MK5684. We also touched upon hormone replacement therapy. So, Jerry, can you put a slide up? What we'd like to do is, you've heard a lot of words, a lot of terms. So, and if you could go to the next first slide, and we'd like to just identify some terms. So what do we hear? Metastatic castration-resistant prostate cancer. So metastatic castration-resistant prostate cancer, it's cancer that's spread and no longer responds to hormone-lowering treatment. So we know what metastatic is: cancer that's moved outside of the location of the primary location of the cancer. Castration resistant was very important, something term that we needed to learn. Cancer continues to grow even after treatment lowers male hormone levels. ADT. This another term that you may hear that in the discussion, other than ADT, androgen deprivation therapy, is NHA, which is next generation hormone agents. Okay, these are prostate cancer treatments that block hormone signals. We talked about hormone pathways used by cancer cells. Taxane, and I want to bring that up because you're going to hear about taxane chemotherapy. It's a type of chemotherapy used to kill or slow cancer cells. Prior taxane treatment helps distinguish Omaha-003. Palliative care, this is supportive care. Next slide, Jared. Talked about clinical trials. We talked about the fact that phase 3 is a later stage study that compares study treatments and treatments doctors currently use. Treatments doctors currently use, another term would be standard of care. We're going to go in detail about Omaha-003, Omaha-004. We talked about MK5684 over Vesistat. That protein, one of the detailed proteins that play a role in the steroid hormone pathway is CYP11A1. And we don't think that they'll throw that out at you, but just that you've heard it. Next slide. And some key topics, and you'll hear about it, and we may ask some questions about hormone replacement therapy. Okay. These are examples, fludrocortisone or dexamethasone are the two drugs that you'll hear about when we talk about hormone replacement therapy. Androgen crisis it's a serious medical problem, but rare. Very low steroid hormone levels, and you need to seek medical help right away. And randomization was another thing. Now, that's a way, it's a computer assigns the participants in the clinical trial. So there's no bias associated with that, so people can be trusted. And I think that those are the terms I wanted everyone to hear. And let's review. Now we're going to transition back, Jerry, if you could drop the slides, and let's ask some questions. Now, this is a question that falls under the treatment. Where do clinical trials fit in the metastatic castration-resistant prostate cancer journey?
Well, so clinical trials can happen at each setting that you have in metastatic disease. So you can have, so when you're found with metastatic disease, virtually almost everybody who's not received hormones before will be sensitive to hormones. So we call that metastatic hormone sensitive prostate cancer.
Right.
We have a number of trials in that setting. Then you develop resistance to hormones. You will have trials for first line CRPC. Then if you receive one line for CRPC and you go into the second line, you have trials for second line.
So is that ADT? What's the first line? Is ADT the first line? Or
Not
is it
just that ADT.
no,
It used to be just ADT. ADT is hormones, right?
Right.
We no longer offer just hormones to most patients with metastatic disease. So we now do a combination regimen that can be 2 drugs or even 3 drugs.
So do you have to fail on one of these novel hormone agents?
Yes.
Or just one?
Yeah.
Okay.
Correct.
And then if you fail on just one, and the cancer has moved outside of the location, the primary location,
right,
or location of origin, that's officially metastatic castration resistant?
Correct.
Just one. Okay.
Correct. Whether you fail one combination, as long as you fail hormones and you have stage 4 disease, that's automatically you have metastatic CRPC. How you get there, it depends on the treatments you received. So the only thing common is the hormones. You had to have progressed on hormones, but you could have progressed on chemo as well, right?
Okay.
And so how you get there can be different depending on your pathway, because not everybody gets the same thing getting there. But there's the common theme here is you had to progress despite low levels of testosterone.
Okay, so we understand what metastatic castration resistant is. We know that we don't have to have 4 or 5 different novel hormone agents. We can just fail on one. Now, let's move to this next question. And I know, I mean, there was a slide that you put up, arrows all over the place. There's a lot of information on that slide that's comparing the two, clinical trials, Omaha-003 and Omaha-004. Can you explain the difference between the two in 1 or 2 sentences?
Yeah, it's just a setting. So Omaha-003 is late line because
So late line for a patient. What does late line mean?
Late line means you were not just diagnosed with mCRPC. You must have received other treatments as well. Does that make sense? So if you look at basically the settings within mCRPC. So
Right.
they're both mCRPC, but the Omaha-004, and it's the opposite. It's counterintuitive. Omaha-003 is post chemo and ARPI. Omaha-004 is pre-chemotherapy.
Okay.
And the reason why those trials are happening, because if you look at the course of metastatic prostate cancer, you can be in different settings, right? You can be not as heavily treated or not exposed as many treatments as other patients, right? So
Mhm.
that's the attempt of identifying the signal, or the benefit of the CYP11A1 inhibitor compared to standard of care, whether or not you have
Okay.
received other therapies. So it's about the setting, because the design is very similar.
Okay. So we know that if you have or have not had chemotherapy, taxane chemotherapy, correct? Okay. So that's okay. So, and then what's interesting is that you could participate in 004 after you fail one hormone, novel hormone agent.
Correct. That's 04.
But before people start you on a chemotherapy, you may have gone through 2 or 3 failures on novel hormone therapy. So you're really in this position, 004, starting it as in an early stage.
Yeah, but that's not considered early for us,
Okay.
right? So yes, there is if you're asking basically is, do patients with mCRPC get exposed to many hormonal treatments? The answer is yes.
Right.
Can you fail several hormonal treatments and still be eligible? The answer is no,
Oh, okay.
right? So
Right.
if you look at Omaha-004, for example, you're not allowed to progress on more than one ARPI,
Wow.
right? It doesn't
Right.
matter which one, but you can only have progressed on one ARPI. Now,
So
there's
this
all
is
the
what.
details. Sometimes,
Mhm.
Keith, sometimes you've been on two, but one of them you didn't really progress. Let's say you started on one and then you had a problem, a safety problem, and the doctor changed you from that one to another one, right? Those are nuances that need to be discussed with the care team and the
Mhm.
monitor. What I should be telling you is this: if you were exposed to 2, 3 hormonal treatments, you're not going to be eligible for the Omaha program specifically. You might be eligible for other trials, certainly,
Oh, I see what you're saying.
right?
Okay.
Because each trial has their own eligibility criteria,
Right. So,
and we don't
so
change them. We cannot bend the
okay.
rules, if you will.
So if a person is fails on one and then they go from one to chemotherapy, then they can
Correct.
participate. But if they fail on a couple of novel hormones, they won't qualify for either.
Correct. So the message is, if you have Omaha available now for you, and you're debating whether or not you're going to go on a second ARPI, the best way to do it is on the trial.
Okay. 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 That's good. And I want everybody that's clear for everyone to get understanding. So this point is very important because it brings back the fact that we have to make sure patients keep track
Mhm.
of their history and know what happens when you change your medicine. It's just not like, oh, well, I'll get to it later. We have to be conscious of the fact of the medicines that you're on and when you're changing. Okay.
That's right.
So the next question that comes up, if you had a relative
Uh-huh.
and you're sitting at the kitchen table, even though it's kind of hard to discuss prostate cancer at the kitchen table, how would you have them understand this whole how MK 5684 Vesistat works in the simplest term?
Yeah.
Or
So,
Mhm,
so basically, you explain. Listen, so you measure testosterone in men.
mhm,
Women have minimal amounts of testosterone. Biological male, by the way, that's what
mhm,
we're alluding to.
right,
Biological male can have prostate cancer because they have a prostate.
right,
Biological women don't. So just to make the
right,
distinction from
right,
biology. So testosterone, you measure it, right? Might be
right,
400, 500. Mine might be 400, 500 right now, 600. So that's normal levels. if I lower that to like, let's say 7 or 8, and I can do that with a shot or with a pill, what happens is the testosterone in my body doesn't, when it gets inside the cells, it changes into something called DHT.
Mm-hmm.
And DHT tells the cell to grow and proliferate and thrive.
Mm-hmm. Right.
At lower testosterone, that doesn't happen as much. The receptor doesn't talk to the nucleus of the cell, and the cells don't, it goes dormant. So your brain tells the testes to produce testosterone, and the testosterone goes in the cells and tells them to grow and proliferate and thrive.
Mm-hmm.
So when you block that, either you block it here or you block the receptor. That's the pathway that we're describing. And let's call it androgen pathway or hormonal pathway.
Right.
So this therapy, it's a novel generation of blocking that pathway, right?
Right.
And by doing so, you are optimizing that inhibition. And by doing so, the cancer goes dormant, basically.
Right.
So we're not expecting to see cure because it's hormonal manipulation. What that means is the cancer goes asleep. It's different than it's going to be dead forever, right?
Mm-hmm.
You know, the hormones, all of them don't have the ability to get rid of the cancer, disappear because of stage
Mm-hmm.
4 disease. However, they have the ability to put the cancer to sleep for a significant amount of time. So this medication falls under the mechanism of action that I just described.
Okay. So I think we have a better understanding of it. And I know it maybe complicates a lot of people, but we produce steroids. We know that the steroids um, in that pathway play a role in specific steroid-like compounds play a role in the cancer growing.
So Keith, I would clarify further. The hormones that we're talking are steroid hormones,
Correct.
right? Because people who hear steroids, they'll think prednisone or prednisolone or dexamethasone, right? We all use steroids. So these hormones that we're describing that happen, that we're describing, these androgen pathway, it's steroid hormones.
Steroid hormones.
Right. And
Right.
so when you look at the production of steroids, whether it's steroid hormones that play a role in sexuality as well as role in the kidney, etc., they are produced not all of them, but they mainly produced in the adrenal glands.
Okay. So within what we're saying is so we shut down all the steroids that are being produced,
Steroid hormones, yes.
steroid hormones being produced. Okay. Now the next step is tell us about the introduction of hormone replacement therapy. So how does help us how we
Yeah.
transition into this? Okay.
Right. So if you look at the steroid pathway of producing those hormones, all of them, right?
Right.
You know, so it's not just we're not just talking about testosterone, right? We could be
Right.
talking about aldosterone, etc. That we have different hormones in our body,
Mm-hmm. Yeah,
not
it
just
regulates the immune
not just the
system,
male hormones.
regulate immune system, metabolism. There's a lot of things that the hormones do. Okay.
Exactly. So, you know, if you look at we actually, the technical term is adrenal steroid hormone pathway or synthesis pathway, right? That's
Right.
what we study, right? And I don't want to make it too complicated, but bottom line, if you go, you will find the CYP11 A1 there, right? So
Right.
by doing so, you're shutting down the production of those hormones.
Correct.
Because you're shutting it down and you need them to leave, you need to get them.
Right.
And that's the story behind the replacement therapy. I'm giving you what you
And
don't.
and they're only taking two replacements,
Yeah,
and then that
fluorocortisone and
helps.
dexamethasone. Yeah,
Yeah.
yeah.
Okay.
So
Okay.
it's the same as if I remove your thyroid, right? Your thyroid produces thyroid hormone.
Right.
If you remove your thyroid, you won't have it, right? You're not
Right.
producing, but you need it. So guess what I'm going to do? I'm going to give it to you.
Right.
Right.
Okay.
That's
All
it.
right.
That's seamless.
That's it. It's just that simple. Okay. So that was a good example too, because because instead of just bringing it back to home to something that's already being done today, replacement therapy for a removed organ that produces a product for the body. So
Yeah.
then let's go back. we talked about hormone replacement therapy, and you talked about guinea pig and research. What about this concept of placebo? Is there a placebo in this trial?
So
Is it standard of care? It's always standard of care.
no, it's not placebo. There's standard of care, and you know what you're getting.
Yes, yes. And then
Right.
we wanted everybody to know what they're getting. That's
Correct. And
okay.
doctors know, patients know. There's no placebo here.
Mhm. So
Like,
is there so there's hormone replacement therapy in 004 and 003?
so hormonal replacement therapy is only if you get the opevesostat.
Correct.
Right. So if opevesostat shuts down that production of steroids, I'm going to give them to you so you don't miss them.
Okay. All
Okay.
right.
But you can also, but you can be randomized. And remember, we're looking over 1,300 patients, each trial, if you will. I mean, if you just look at if you look at the Omaha-004, for example, we're talking over 1,300 patients. Half of them are not gonna get opevesostat, right? They're gonna be getting the standard of care, abiraterone or enzalutamide, which I give to patients outside a trial.
Mhm.
Those don't are not going to get these other steroids you alluded to, right? By the way, the abiraterone that we prescribe every day, we do give prednisone, low dose of prednisone, because it can also give you some adrenal insufficiency
Right,
and
right, right.
give a little bit of steroid as well to prevent
Okay.
that, right? So this is not completely odd or new. We just explain why we do it. So, but you don't have the risk of not getting treatment for prostate cancer. I hope I make that point clear.
Right.
Right. You're getting a treatment that's available, that doctors do it all the time, particularly in
Mhm.
America, or you get epovesostat, which is a newer generation hormonal inhibition, if you will.
Okay.
And that's pretty much the options that you get.
Okay. So let's transition a little bit to some audience questions.
Sure.
Okay. Um, One here, what if I already had abiraterone or enzalutamide?
Both. So if you got both,
Or I just say or. I think you
oh,
said,
that's not a
yes.
problem. If you get
Okay.
one of those, if you randomize on trial, you have to say, if you randomize to the standard of care, you'll get the one you have not received yet,
Okay.
right? Because they're
Right.
both available
Ah,
or
I see.
allowed on the trial.
On the trial.
You can do abiraterone, you can do enzalutamide. So let's say if you receive abiraterone before, you can get enzalutamide now on trial. If you receive enzalutamide before, you can get abiraterone on trial.
Okay. Okay.
Yes. So that's not a problem.
Mhm. Now, this next question. Okay. Metastatic castration-resistant prostate cancer.
Uh-huh.
Metastatic doesn't have to mean to the bone. How would you define, is metastatic just outside the prostate? So if you had no tissue involvement outside the prostate, is that still classified as metastatic? Yeah, I think,
So most patients will have disease in the bone, 70 to 80%.
right.
Half of them are going to have cancer in the lymph nodes.
Hmm.
Up to 20% will have disease in the liver, lung, or soft tissue. All of this is metastatic disease.
Okay. All right.
Yes.
Now, and I want to be clear, you made a statement, and this is the same question here, but I
Uh-huh.
just want everyone to understand. The question is, can I leave the trial if I change my mind? And the
Anytime.
question is, yes.
You can sign and 5 seconds later, change your mind, you come off trial. That's it. Nobody's going to chase you to keep doing it, right?
Okay.
You are the boss, you are in charge. The team is there to help you. You can come off anytime for any reason.
Mhm. Now, the so go back a little bit, and we went over it quickly, but it was adrenal insufficiency and it being um, kind of an emergency situation, but it's not as if there's, I won't say, there are emergency situations that occur in a lot of different situations in medicine. And
Okay.
it's and so the question is, can you help them better understand adrenal crisis? Because they'll hear words, it's a crisis, and and it's sometimes the words used are kind of sensationalized what's really going on. So they're more comfortable understanding um, having this medical problem.
So, well, scientifically, if you need steroids to live and you don't have them, in a matter of days to weeks, you're gonna shut down. Your body's
Right,
gonna shut down, right?
right,
That's the crisis we're describing.
right,
How often does that happen? Very rare,
right.
right?
Okay.
Very rare. I don't want to quote the numbers because, first of all, on the trial, it might be not, it's not in the public domain. It is in the public domain, was run previously. I can tell you it's rare. And why? Well, because you are getting replacement treatment. So I think it's important to have the knowledge about it, and even have that conversation. But the teams that have this trial are aware of this because it's part of their training to take the trial on. So so I understand it can create some concern. At the end of the day, if someone is not comfortable with the concept and is
Hmm.
sleep better at night thinking, "Oh my God, I'll have a crisis," even though you're getting treatment, the replacement treatment, maybe it's not the trial is not a good fit, right?
Okay.
I mean, you should not do something to be miserable every day. That's not the
Right.
intention. I can tell you from my experience as an investigator, that has not been an issue.
Okay.
I explain what it is. They have our phone. I never got a call personally about it. They understand why they're on the steroids. That's it, and people understand that. But I would say, I'll admit that if the idea is just so scary or so concerning that, oh my God, I don't want to even risk in theory, the 1%, let's say, or 0.5%, whatever that number low is, then maybe it's not a good fit then, right?
Okay.
But the same applies to the other medications like abiraterone. I'll give you low dose prednisone,
Right.
right? And so it all comes down. You have to be careful with the medication you go on, right? At the end of the
Right.
day, we're treating patients, but they need to feel comfortable with the treatment they go
Right.
on, and that's applicable to this trial as well as to everything else.
Right.
But that's
And
what
you
the
made
concept means, and I
Mhm.
will say it's a rare event.
Okay. And you made a very important point before. And then, clinical trials, you got a lot of people watching. And so you're going to get better care, consistent care. People are going to be monitoring you, encouraging you not to miss an appointment or anything like that. But what happens if you miss um, replacement therapy? Is that a problem?
Well, compliance is always a problem, right? Because
Right,
if
right,
you
right.
don't have medication, you're gonna have problems, either because the
Right,
cancer won't be under control, it will grow, or something else, right?
right,
If your question is, I miss one day, I miss two
right.
days, there's
Well,
actually a plan and a protocol for that.
okay, okay.
So,
Even, yeah,
oh
because
yeah,
things happen. I'm just saying things happen. We don't want it to happen, but we know
right.
that things happen, and it's
No,
not
I mean,
just yeah.
right. I mean, of course, we encourage. I mean, compliance is very important. And if someone tells us, "Doc, I want to do this, but I'm not going to be compliant," a
Mm.
significant amount of
No,
money,
I was looking at say for example, a certain situation where a person was leaving the country, and
right?
they're going to miss that particular day. It doesn't have to be exactly on that day.
Life happens, right? And we
Right,
have a
right.
plan in action for that. In fact, I mean, some of these medications have a half-life longer than one day, by the way. So
Okay,
that is not, nothing's going to happen other than it's important for us to be aware. It's important that we have this conversation and we give them a plan. So, for example, I've written letters if patients leaving the country, to explain why they're taking the medication they are on so they don't get into any kind of trouble. So
okay,
that's the kind of thing that the care team, the research team, works as a partner and collaborates with the patient to help them out, right? We're here to help people live their lives at the end of the day. So I mean, if we're here, if I get a text now from a patient of mine saying, "Hey, Dr. Brada, I didn't take the steroid," I'm going to give him a plan which will be compliant with the protocol. That's all.
okay,
So
okay.
what I should say is this: it's extremely unlikely we'll find a situation that gets us surprised because the protocol is done in a
Protocol.
way that we have thought of, folks have thought of all the scenarios. So we have a plan in
Okay.
action for whatever might happen.
The last question that I had was, is what would you ask? What are the three most important questions that a patient, or what questions would a patient ask um, during the next oncology appointment?
In the context of the trial, or
In context of the trial, if they were wondering about participating in a clinical trial,
yep,
what would be the questions that they would ask their oncologist?
right. So if I was the patient and I was offered this study, I think it will help to understand the logistics around the study,
Hmm.
frequency of the visits, what is required from me and my
Hmm.
family members in terms of how often do I need to go back to the center,
Right.
how often do I need blood work, how often do I need scans, and where can they happen, where do they happen?
Okay.
Uh, Contact information, like, who's available if something were to happen, like who do we
Right.
call, who do we speak with, who's going to be the team
Mhm.
available, and how do I reach out to them? So that would be the second. And then are there other trials that
Right.
are available to me, and does Omaha precludes me from other trials, right?
Mhm.
So because the idea of this is being a continuum and making this a chronic disease, therefore the goal of
Right.
the game
Right.
is you go on Omaha, while it works. When it stops working, you should go on something else, and so forth. So having that sense of what happens down the line, in terms of what options may be available, it's also important as part of the conversation with the provider, and the care team should be able to answer those questions.
Okay. All right, Dr. Barata, I really thank you for taking the time with us this evening about going over the Omaha-003 and Omaha-004 clinical trials. We really appreciate that, and I think that the audience also really appreciate the amount of time that you spent. So,
That's great. Thank you for the opportunity. Always a pleasure.
thank you again.
Thanks so
You have
much.
a nice evening.
Bye bye.
Okay, bye.